questions as possible. I'd also like my other senior faculty who are on, like Munish and Alok and Zoor and everybody else. I could see Atul for a moment. Please chip in at any time to ask any questions. Let's make it as interactive as possible. So go shoot, Nagesh. It's yours.
Yes. Hi, good evening, everyone. Today I'm going to present early carcinoma tongue. So our patient is a 65-year-old male. He is a shopkeeper hailing from Delhi. So he presented to OPD with ulcer over the tongue on left side since 2 months. This tongue ulcer is associated with bleeding whenever he takes hot food, and also associated with pain occasionally. And he doesn't have any neck swelling, and he doesn't have any symptoms suggestive of oropharyngeal or laryngeal lesions. Patient giving history of diabetes and hypertension since 15 years. Patient is on medication. According to patient, diabetes and hypertension are under control. Patient also giving history of smoking. History of smoking. He has history of 15 back years of smoking, and he quits 2 months back when he noticed ulcer. Coming to examination, on systemic and general examination, patient was moderately built and moderately nourished. ECOG performance status is 1, and on local examination, patient mouth opening is adequate, and is able to pass more than 3 fingers. Is able to pass. His mouth opening is more than 3 finger breadth, and his orodental hygiene is reasonably okay, and he is partially edentalous. And on inspection, there is a 2.5 cross 1 centimeter pinkish proliferative lesion noted over the left lateral border of the tongue, and which is not crossing the midline, and base of the tongue and floor of mouth is not involved. On palpation, all inspectory findings are confirmed, and tumor on palpation is thin, and no ankylosing. On neck examination, no palpable neck nodes seen, and endoscopy done. Patient oropharynx and larynx is normal.
Okay, Nagesh, go back to the history slide. Let me ask the other people who are there, the other 6, whether they wanted to take anything else in history, or do you all feel this is a complete history? Any of the other 6 who are listening in?
Yes.
The symptoms regarding any distant metastasis, which would be like any chest pain, bone pain, or symptoms or significant anorexia or weight loss, nutritional component.
Okay, I'm going to stop you. Please tell me, is this metastatic disease constitutional symptoms common in early tongue cancers?
Not so much, sir, but if you do.
Yeah, so for a short case, I'd rather you not dabble into those kind of things which the examiner will want to trouble you with. So really, in this case, it is not very important. Details of habits, he has already said, because I can see Colonel Azad type history of habits, but that's already been taken. Is a family history important in oral cancers?
Yes, sir.
For what?
There are some syndromes are associated with oral cancers.
Okay, can you name 1 or 2?
Lee-Fraumeni syndrome. And
is Fanconi's important?
Yes.
Ataxia telangiectasia, Bloom syndrome, xeroderma pigmentosa. These are all
not xeroderma pigmentosa. Xeroderma pigmentosa is more associated with skin cancers, but you're pretty close. There's something that happens to the palm and plantar surface known as disc keratosis congenita. And I think in my career, I've seen it twice. So always, if you have a nasty examiner, just look at the palms and see if it's a little keratotic. You may want to make a note. Great. Can someone please qualify pain quickly? And I know this is a question asked very often. If you get pain from an ulcer, where will it be? The reason I ask you this is because you said the tumor was thin, and thin tumors usually don't cause too much of pain. But if you get pain, uh, uh, could it be radiated or will it be local? Ganesh, anybody else? Nagesh, anybody? Quickly, you must
That
know
it's
the.
local pen.
Okay, you must know the path
It's
of
local
radiation.
pen.
Okay, if it's radiated, it goes to the ear, and you must know the path of radiated pain to the ear for an oral tongue lesion. Can you quickly tell me, any of y'all?
Maybe
I need an afferent, I need the ganglion, and I need the efferent.
Sir, from the tongue and teeth, so it can radiate it from the fifth nerve to.
Listen, I don't want to be
Sir,
nasty, but if you're going for an MCH, if you give some fifth nerve, so basically the afferent is the lingual.
Lingual.
It will go up, and the ganglion is the
lingual and
Bessarian ganglion, and it will come back efferent to the auricular temporal. I don't know if I'm seen, but I'll quickly tell you the efferent. It's very simple to remember. If you have oral tongue lesion, the pain is referred in front of the pinna, and it's auricular temporal. It's in front of the tragus. If you have a base of tongue lesion, the pain is deep in the center of the ear, and it's the tympanic nerve, which is the efferent. And if you have in the larynx, the upper part of the larynx, the pain is still posteriorly over the mastoid, and it's the Arnold's nerve. So it's important, if you come from behind forward, it's A, that's Arnold's, T for tympanic in the middle, and AT in front. So please remember it like that. I remember it that way, and I've remembered it for 30 years. Okay, next slide, please. Please read it up. Next slide.
Yes.
Great. Other six panelists, do you all agree with what he said? Anything else you all want to say in examination? Anybody is happy with this tumor on palpation is thin? Listen,
no.
guys, speak up, others will finish our 45 minutes. Or otherwise, just say pass, then I can answer, or I'll get someone else to answer.
So we can use the term pinchable for tongue tumors.
Pinchable.
Yes, sir.
What do you mean by pinchable? Okay, quickly, I want to say, whenever you present a tongue or a buccal mucosa or anything else, it's nice to describe the things which you have done. And it's important to describe its relationship to important structures or important landmarks of that organ. So let's do tongue. So you should say it's a 2.5 into 1 centimeter lesion on the left lateral border of the tongue, which is missing in your present. It is far away from the tip anteriorly. It's far from the circumvallate papillae posteriorly. Its relationship to the floor of mouth and mandible laterally, and its relationship to the midline medially. Exactly the same when you all present buccal. In buccal, you should say its relationship to the commissure, its relationship to the upper and lower GB sulcus, and its relationship to the retromolar trigone. So please describe the extent.
Yes.
When you say palpation, don't say the word thin. Generally, if you pinch the lesion, as someone said, and both your fingers meet beyond the lesion is less than 4 millimeters, and you don't need to do a neck dissection in old thinking. So you can say, I pinched the lesion, it is thin, and it is thin because my index and my thumb could come together in the substance of the tongue beyond the lesion. Other experts, Akshat, Alok, if you all want to add anything, or we'll move on. Okay, go ahead, Nagesh.
Yes. Sir, based on clinical examination and history and clinical examination, so my clinical impression is a patient may be having a malignant tongue ulcer on left lateral border of the tongue, probably squamous cell carcinoma, because most common histopathological variant in oral cancer is squamous cell carcinoma. Maybe carcinoma left lateral border of the tongue, clinically T2 N0MX.
So you said quite categorically squamous, but you said maybe carcinoma. Why did you say maybe carcinoma? What is the differential you have in mind?
Sorry, sir. I would go for it is carcinoma only, not maybe.
Very good. Excellent. Wise guy. Because if you said maybe, some nasty examiner like me would ask you a differential. Could it be tuberculosis?
Uh, no, sir.
What's the most common condition on the tongue, benign, that you mistake for a carcinoma?
This
Granular cell tumor, sir.
Absolutely. Not granular cell, but what we call the eosinophilic granuloma. It's generally adjacent to the sharp tooth, and you get a kind of a granuloma formation, which could have an elevated thing. It mimics a raised everted edge, and that's why many people do it, but it's juxtaposed to a traumatic teeth. And that's another thing that you need to say, which you didn't say properly in your history. When you said that he has partial dentures, you should very clearly highlight that the teeth adjacent to the lesion are normal, or they are sharp, or they are carious, or they are impinging on the tongue. That needs to be quantitated as well. Okay, great. So carcinoma of the tongue, what will you do for this patient? Go to your next slide.
uh,
Okay, quickly, can you tell me why do you say carcinoma?
uh,
You changed. So remember, in MCH, in MBBS, you just have to know the answer. In MS, it's answer plus Y. In MCH, you need to know answer Y and the biological basis as well. So please tell me, why did you say carcinoma?
patient giving short, it is a onset is more or less it is almost acute onset, and
Good.
the progression of ulcer is fast, and it is associated with patient habits also. Smoking, he is giving history of smoking, so
So, so you're absolutely right, but just choose your words carefully for the examiner. Say, sir, it's a short duration.
yes,
He's a person who's tobacco, stroke, alcohol user. It's not related to any trauma in the teeth. It's insidious, and probably it's a carcinoma.
yes,
If you say it's growing fast and all, he will ask you what's the tumor doubling time of oral cancers, and again you'll get into problems. So you are absolutely correct, but choose your words a little carefully when you talk to an examiner.
yes.
Okay, great. What will you do for this patient?
Uh, Sir, I would like to do first imaging in the form of MRI head and neck with contrast,
Hmm.
and followed by incisional biopsy from the junction of the abnormal tumor and normal mucosa.
Okay, so two questions I'm going to ask you. It came up in the Tata Hospital clinic, but I wasn't very happy with the answers there. Will you do the biopsy first, or will you do the imaging first?
Sir, I would go for imaging first, then I will go for biopsy then.
So you did the imaging and then you did the biopsy, and it came as an eosinophilic granuloma, and you wasted the patient's 18,000 rupees on his MRI.
Uh, Sir, as we said, that history also strongly favors the malignancy. So I feel that sometimes we have to overweight. We have to consider imaging first, followed by biopsy, because in
Okay, there's no right or wrong answer. There'll never be a randomized trial, but use your sense, Nagesh. You don't do a biopsy when the biopsy will probably change the imaging findings. For example, if you are treating an unknown primary and you take blind biopsies of suspicious areas of the base of tongue, the piriform fossa, and then you send the patient for the PET scan, you can get a false positive. In this kind of lesion, which is so superficial, you can take a biopsy without causing much trauma. It's unlikely to change the imaging findings. If it's a deep ulcer, which is submucosal, you have to incise with the knife and you might cause edema, which might change the extent of the tumor. In that case, I would probably first do the imaging and then the biopsy. In this case, it's a moot point. There's no right or wrong. I'm not saying you're wrong, but you need to justify why you want to do the imaging first or the biopsy first. So generally the dictum is if it's not going to change the extent, cause false findings in the imaging, you can do the biopsy first. The second thing I don't agree with that you said you'll take it from the edge. If you biopsy the edge of an ulcer, you will have to give the patient local anesthesia. If you biopsy from a representative area, 99% of oral ulcers do not need incision. They can be done by a punch biopsy. And in this patient, you can do a punch biopsy. When do you do biopsy from the junction of tumor and normal?
When we have a patient with a leukoplastic patch or erythroplakic patch
No,
with the
no,
suspicious.
If a
no,
significant
no.
proliferative component is
No, you only do a biopsy from junction in chronic ulcers. The general surgeons will tell you when you have a zone of transition, when you are doing a biopsy from malignant lesion, you have to just take the most representative area, which is not obviously necrotic. People say that you take it more towards the edge because the center necrotic in large lesions which outstrip their blood supply. But you have to just take it from the most representative. If you take a punch biopsy from the junction of normal and tumor in this patient in the OPD, he'll slap you. He'll get so much of pain. You can just take it from a representative area. If you go back to the previous slide, I can show you with my cursor where it is. Yeah, yeah. Is my cursor being seen? Yeah, so you can just take a punch biopsy from somewhere on the top of the ulcer and you're good. So I don't agree with you an incisional biopsy. I'm okay with a punch biopsy. 2 millimeter punch biopsy forceps is good enough. It will be representative and I'll send it. And I'll do the MRI. Why not CT scan?
MRI.
My patient can't afford. He says, sir, do a CT scan. It's cheaper. Even you are more comfortable to read a CT scan. Why should I do an MRI? Just because KK told you to do an MRI, you're doing an MRI.
No, sir. MRI gives better. Now the AJCC 8 included depth of invasion. So MRI gives better idea about the three-dimensional picture of the tumor. Even though.
So your answer is correct, but your justification is not correct. It's not because of AJCC staging. Soft tissues are better delineated on MRI and the tongue is better visualized on MRI. Bone is better visualized by CT scan. So I would like to do an MRI. Is that okay? Fine. It will tell you the depth. It will tell you the extent. It's not because the 8th edition told DOI and that's why we are doing MRI. I used to do an MRI even in the 6th and the 7th editions of AJCC. So your answer justification is incorrect, answer correct, but it is because it gives you better soft tissue delineation. On which image will you best see the tongue lesion? T1, T2, contrast, post contrast. Huh?
T1,
What contrast? Contrast what?
T1 post contrast.
Your image. Is that correct? So the answer that they want is T2 post-contrast fat suppression. Will you remember these three words?
Yes.
T2 post-contrast fat suppression. How do you know whether it's T1 or T2 when you look at an MR?
So T1, T2 images will be bright where there is a lot of fluids. So water is white.
Excellent. So you'll see the spinal cord and you'll see it
Right.
brightly lit, which you won't see on T1, or you'll see the eyeball brightly lit. Okay, great. So that's great. So you'll always do it. What does the axial show you and what does the coronal or sagittal show you? What do you want to look?
Uh, we want to look both axial and coronal, sir. So axial imaging can show whether lesion is reaching midline or not, and coronal will show whether deep this extrinsic muscles and sublingual space is involved or not.
Yeah, so again, answer is correct, but justification, the answer is that the axials will tell you the medial to lateral extent of the tumor. The coronal will tell you the craniocaudal extent of tumor. You must sound fancy with your examiner. Not that it's going up to the midline. It shows you the lateral to medial extent axial, and the other shows craniocaudal extent. That sounds a little more fancy to your examiner.
Sure.
Okay?
Okay.
Excellent. Okay. Go ahead. So we've done the MR. We see a lesion that's going 3 millimeters away from the midline. The muscles are involved. What else do you want to know? I'll tell you the findings. Do you have the images?
Yes, sir, we have the scan. I'll share the screen.
Okay, let it be. If it's going to take time, just forget it. Just tell us what you want to see. Great. I anyway made my points on imaging there, but can you put a representative scan that shows the lesion? Go one higher. Yeah. Maybe somewhere. Anyway, leave it because I don't have a cursor to ask him certain things in the scan. But tell me what all. So we've discussed which images are good. We've discussed on this on the various axial and craniocaudal. But tell me what else do you want to know on image?
In imaging, we can see the extent of the tumor, and we can know the nodal status also.
Excellent. So you can see the nodal, you'll see the extent of the tumor. Is it important on imaging to find out whether the extrinsic or the intrinsic muscles are involved?
Yes, sir.
Yes, sir.
It is?
Yes, sir.
Yes.
It's the earlier staging had extrinsic muscle involvement, making it T4. It's difficult to find these muscles on the imaging, and that's why now we go for depth of invasion. What are the extrinsic muscles of the tongue?
The genioglossus, the hyoglossus, and
Hyloglossus and palatoglossus.
palatable.
Stylo and palato.
Stylo
Which
and
ones
palato.
are definitely seen on imaging and which may not be seen on imaging?
The genioglossus and the hyoglossus are definitely seen.
Absolutely. So you must know this as well. The genioglossus is the bulk, it's in the center. The hyoglossus makes up the lateral boundaries of the oral tongue. The stylo and palato may not be seen. But I will tell you a tip which I can see some few seniors. I can see Saurabh there, Gagan there, Pooja Pal there. To me, I always try to look at whether the extrinsic muscles are involved, whether it's coming down into the sublingual gland, into that space, because that makes it very important on my approach to the tongue lesion, whether I'm going to excise it per orally or I'm going to do a pull through. So please try to always gauge the craniocaudal extent of your tumor on the imaging, because sometimes pinching and an evaluation under anesthesia may be slightly fallacious. You'll miss a nodule deep down and these guys recur very, very quickly. Okay, great. So you've done a biopsy. It's squamous cell carcinoma. We've seen this lesion on the MR scan. There is a doubtful node at level 2 on the same side, which they say correlate clinically. It's indeterminate. What do you want to do for this patient? Nagesh.
Yes, sir. I would like to go ahead with surgery in the form of taking a wide excision of the tumor.
Stop. We've got Gagan and we've got Munish, two very strong radiation oncologists. They say that they are going to give radiotherapy. They say, Nagesh, why do you want to cut the tongue? I'll cure this patient with radiotherapy. And this patient has gone and consulted them at Rajiv Gandhi and at Max. And then they come back and say, these two guys are telling me radiotherapy, you're telling surgery. Justify. Nagesh. He's gone to sleep. Munish has come forward.
Yes.
Radiotherapy, I can make out. Nagesh, are you there? Okay, next candidate. Nagesh is frozen.
Sir,
Abhijit, come on,
Yes,
Abhijit.
Sir, in early stage oral cavity malignancy, we want to use single modality treatment. Radiotherapy is as good as surgery, but then there are points which are in favor of surgery, like it is a quick. We can do one-step surgery of the primary as well as we can treat the neck, and because head and neck malignancies are notorious for second primary malignancy, so we can spare our radiotherapy for future use if in case it is needed.
Excellent.
And
So, Abhijit, what you have to say, it's quick, it's simple, it does not cause functional or cosmetic problems, can be repeated, and radiotherapy can be kept in abeyance. I finished the same thing in exactly one line and I told the same points. So these are pet questions of examiners. Please mug up these 4-5 words, and when you go there, just vomit it out and wait for the next question. You have told the same thing, but you have told it in a little longer thing. What is the ideal lesion for radiotherapy? If you in tongue, if Monish had to treat a radiotherapy, how would you choose which is the ideal lesion? What are the characteristics? Radiation oncologists on the panel, please. Who are the radiation oncologists? Put your cameras on, please.
So T1N0 lesion.
Yeah. What is the characteristics?
So an exophytic tumor.
Exophytic. So it should not have deep infiltration then, or a superficial. Anything else?
No. So
Only
N0.
no. Why you that we'll discuss when we discuss the neck. Does it have to be accessible? If it is absolutely posterior, if it is sitting close to the bone, if the surface dimension is 5 centimeters and it's superficial. So
Sir, a small exophytic anterior lesion.
So basically the answer for that is 4 points. A small lesion that is superficial, away from bone and accessible. Manish is smiling, so I think my answer is okay. I'll pass. क्या Manish बराबर की नहीं?
Sir, perfect, sir.
बस ठीक है. So
because brachytherapy, we always are discussing with the brachytherapy, and then
yeah.
I always feel, sir, that neck addression is always a problem. The guidelines are not proper how to address the neck if we do brachy in these kind of patients.
So great. So we agree with Abhijit and Nagesh that we will go for surgery for the reasons that highlighted. How wide will you take the lesion? Abhijit.
Sir, I would like to take out the lesion with 1 centimeter of margin all at once.
Why not 7 millimeters? Why not 1.5? Why not 2.3?
Sir, tongue tumor have characteristics of undergoing contraction as soon as we excise the tumor, and plus we have almost 30% contraction after fixation in formalin. So the ultimate, my ultimate goal is to get a 5 millimeter clear margin in the post-operative.
So great. So you should take a minimum of 5 millimeters. You place your knife a little away from that because there's a 25 to 30% contraction of the specimen. Are you aware of any paper that says you can take less than 5 with good results?
Yes, sir.
Quote the paper.
There is a paper by MSKCC, Dr. Snehal Patel.
Great.
Sir,
What is the cutoff that they have used?
Sir, they have seen all the cases where, sir, they have used 2.3 millimeter as the cutoff.
Excellent. So, okay, we are not going to waste time, but generally the dictum is 5 millimeters and you will take it wide enough so that you get clear margins. Great. Okay, lovely. What will you do for the neck?
Sir, I would like to, sir, this case is because N0, I would like to go ahead with a supraomohyoid neck dissection level 1, 2, and 3.
But again, they went to All India and Dr. Alok said, don't do the neck. He said, ठीक है, 20% में आएगा. Why should you do the neck?
The T2 lesion have chances of occult metastasis in the range of 25 to 30%.
If it's T1,
sir, even if it is T1, it has chances of occult metastasis to the level of to the range of 19%. So
excellent. So if it's 19%, you're saving a neck dissection in 81% of people.
Sir,
that's all. Don't do the neck.
There is this trial from Tata Memorial Hospital where they have seen the benefit of elective neck dissection over therapeutic neck dissection in early oral cavity malignancy. The bulk of their lesion were early oral cancer, were tongue cancer, and because the study was not powered to see if the effects. I mean, they have shown that.
Listen, don't get confused. Know very categorically that doing neck dissection prophylactically in N0 saves life.
Yes.
Dr. Hospital paper, there's another trial that has come known as the SEN trial. There are at least 8 meta-analysis, and recently there's an which has just come out in the JNCI looking at 5,000 patients, and all of them show that there is benefit even when you do it in a T1 cancer. Will you remember that? Yes. So you should say that there is compelling evidence now that we should do the neck dissection. We'll go back to the tongue, the primary that you said you'll do a wide excision glossectomy. Can you tell me the types of glossectomies?
Sir, there is an Italian paper which where they have described types of glossectomy, and they have shown anterior partial. I mean, it can be a partial glossectomy, it can be a hemiglossectomy, it can be a subtotal or a total glossectomy.
I thought there were 5 types. So the lead authors were from Fossio Chisia's group, but they also had experts from Canada, from US, and from Sao Paulo, Brazil, ratifying this classification. Quickly, can you tell me type 1 is what?
Sir, I'm not very...
Type 1 is mucosectomy. Type 2, wide excision glossectomy. Type 3 is divided into A and B. Type 3A is hemi. Type 3B is compartmental, where you go down. Type 4 is subtotal. Again, divided into A and B, subtotal, near total, and type 5 is total. Youngsters in the audience, please Google, read the types of glossectomies, because again, some nasty examiner will ask you and trouble you. It does not make much sense. But again, for the seniors listening on this, I kind of, on my imaging and on my clinical examination, mentally make an impression whether this is going to be type 1, 2, 3, 4 or 5. Type 3, 4 and 5 will always have a pull through. I'll never do it per orally. I'll take out the sublingual gland, I'll take out the submandibular gland, and it will be in continuity. So I just urge you, and I just think it's better to do it that way. It's biologically much better, and we are not going to discuss anatomy, lymphatics, where they lie. That we can do at one of our conferences. For the youngsters, please remember the types of classifications. Abhijit, do you want to do a neck dissection, SOHD? Again, they went to, I'm just trying to, Akshat. Akshat has come back from UK and he says, what SOHD? I want to do a sentinel node biopsy. Is he right?
Sir, sentinel node biopsy is, I mean, we have got a recent French trial and a previous Japanese trial, both RCTs, and both have shown equivalence in the survival for either we are doing elective neck dissection or we are doing sentinel nodal biopsy. But then sentinel nodal biopsy, sir, the problem is
What was the benefit in these two trials? What benefit did they show? They showed equivalence. What was the benefit they showed?
Sir, the French trial did show that for the, there was till 6 months there was better shoulder function for the sentinel nodal biopsy, but at 1 year there was no significant difference.
Okay, so the postulated benefit of doing a sentinel node biopsy is that you will have better shoulder function. So
yes.
Then why aren't you doing sentinel node biopsy? Telling me that shoulder function is good, there's no inferiority. Do sentinel node. Why did you tell me SOHD?
Sir, sentinel nodal biopsy needs expertise in the form of a good, a trained surgeon, a trained pathologist. We need to have a nuclear medicine backup. We need to have IHCs, and it is even after sentinel nodal biopsy, we did find that there was, they needed to complete the neck in almost 25% of the cases.
Yeah, so basically it's a safe procedure. I don't like your words of saying that sentinel node needs a good trained surgeon. You mean if I do the elective neck, the surgeon doesn't have to be trained, is it? So don't say good trained surgeon, good trained pathologist. You need a good trained surgeon for elective neck dissection more. But it is costly. It's a two-stage procedure. You need expertise. You need infrastructure, and a carefully done neck dissection may not have significant long-term morbidity, and that's why, sir, I would like to SOHD in favor of an SNB. But yes, in countries where they have few, and also your workload in India, we have such a big, heavy workload. It's more time consuming. But in other countries where they have one case every week, they want to do an SNB, they've got a good infrastructure, costs are no, you will not fight if they want to do an SNB. Will you, in your SOHD, will you clear level 2B? Will you clear level 5? Will you clear level 4? Someone told me that you get skip metastasis at level 4.
Sir, we will. I won't clear level 4, level 5, but I will clear level 2B and level 4.
Why? Back it with data.
Sir, according to Liang meta-analysis, according to Pantvaidya paper from Tata, so this level 5 metastasis is very low. It is less than 5%. And even if a patient having level 3 and level 4 nodes, the level 5 mets are less. And
so then why did you say level 4? You're quoting Pant Vaidya and you're saying that you'll do, you're saying she said less. Anyway, in that paper, if 1, 2, and 3 were absent, there was never metastasis at level 4.
Yes.
So it's very, very unlikely, and there's another meta-analysis that has just come in the White Journal. Please Google it and read it. I don't want to waste time discussing because we are approaching the 45 minutes and Vin Paleri and others would be waiting to do their bit. But please read it, and you must know that level 4 is rarely involved in 1, 2, and 3, and even this meta-analysis shows that. In the Pant Vaidya paper was involved in buccal when 2A was positive, and 2B was involved, retromolar buccal, absolutely correct. and 2B was involved in tongue when 2A was positive. So, okay, great. So we'll do 1, 2, 3. I won't fight with you if you fish out a little bit at 4, but don't go all the way to the root of the neck, hurt the chyle duct or tear the jugular at the bottom. It's good enough to do 1, 2, and 3 if the rest is negative. What adjuvant will you give this patient? The final histopathology comes as moderately differentiated squamous carcinoma, PNI positive, depth of invasion 6 millimeters, no nodes positive.
Sir, with these finding, it will be classified as PT2, N0, and M0, moderately differentiated squamous cell carcinoma, and we have only one high risk feature, which is the PNI, and other than this, I mean, these are called soft indicators, sir. So if we don't have two soft indicators, I would like to discuss the case with my patient, and if I evaluate that the patient is educated enough for good follow-up and is living in a place where he is accessible to a cancer center on a regular follow-up, I would like to keep the patient on follow-up.
No, I'm not sure I'm going to agree with you. I want the radiation.
Yes.
So all sensible patients, we don't give radiotherapy, and insensible patients, we give radiotherapy. Is that the answer?
No,
Sir, what I want to say, if the patient is not a good candidate for regular follow-up, if he's living somewhere very far away, a PNI is actually a risk factor for.
This is not an answer that is living far. That's why I'll give radiotherapy. Anybody else wants to answer this?
yes, sir. We will give radiotherapy RT adjuvant.
You will give. Who is
Radiotherapy.
I will go for observation, sir. It is at T2 stage. So even though it is PNI and LVI are risk factors for means recurrence and all. So, but according to now the standard protocol, these are not included in AJCC staging. So I would so it is a early stage cancer T2 N0. So I would go for observation only for this patient.
So let me tell you all, firstly, the AJCC staging need not be gospel truth, and I'll make 1-2 quick comments before I finish. But for the youngsters, usually early stage disease does not get radiotherapy. Advanced T3, T4, node positive, etc., gets radiotherapy. What you call the soft indicators or the indeterminate uh, indications, or not indeterminate, intermediate factors that decide whether radiotherapy, which could be PNI, could be LVI, could be node positive, could be a close margin, could be a high poorly differentiated. Generally in early disease, the dictum is that if you have one indicator, you generally give radiotherapy and not give it. But if you have more than one indication, generally people tend to give radiotherapy. So if I have a depth that is going to 8 millimeters with PNI, I probably would give that patient radiotherapy in my practice. I mean, there are papers that will support me. Someone else might say no, because if this patient recurs, even if he's coming on follow-up, you'll only be able to salvage 1/5 of your patients. So it's better to give radiotherapy when there are two of these factors. And there are many papers. There's a paper by Chen, which has looked at over 500 odd patients, looking at combination of major and minor factors and deciding on radiotherapy. I want to make a point about depth. We've just got out a recent article in EJSO and even the Ibrahimi paper from the same group that took depth into the AJCC. The deeper the tumor, the more it's a surrogate for a more aggressive tumor. They have bad factors in them, and that's why the depth needs to have radiotherapy. But when you treat the neck, and if it's only depth and everything else is negative, sometimes we don't give radiotherapy in our patients.
Sir,
Great.
if I may.
Yeah, who's this?
Sir, Gagan here. Good
Bol
evening. Sir, only PNI should also be considered as a factor for adjuvant radiotherapy, is my thought. Maybe I missed a part of your discourse, but because there was some network fluctuation, but I do feel that if there is only PNI in this patient, even then I would like to offer radiotherapy. I would like to quote an analysis from your group only, where you, it was retrospective comparison, where you compared two groups where there was no indication for radiotherapy, only PNI. The cases were reported in terms of presence of PNI, and radiotherapy helped in improvement of PFS in those cases.
But Gagan, I will quote you many other articles where PN is not really standard. Then people have looked at large nerve versus small nerve, extent, lipids 1 and 2. They've looked at various factors, whether it's in the tumor or outside. There are various factors that have been looked at this. So generally, it's a little contentious issue. So in my book, if it's an early lesion, 5 millimeters thick, only PNI, everything is negative, I will not give the patient radio. Margins wide, 5, 6, 1 centimeter, I will not give radiotherapy. Kuldeep has put, there's no evidence till now supporting adjuvant in less than 10. Totally agreed, Kuldeep, unless there are other factors. So again, if it's less than 10, if it's poorly differentiated with PNI, in my book, that patient would get radiotherapy, particularly if it's a thicker tumor. It's unlikely for a 2 millimeter thick tumor to be having PNI and poorly differentiated. So we agree with you, less than a centimeter we don't give, and even on the randomized N0 trial, that was exactly the criteria that I used for deciding post-operative radiotherapy. Last question to Abhijit and Nagesh, does this patient need a flap?
No.
How will you close?
This patient doesn't require a flap because it is a 1/3 disease.
My God, Nagesh, you're from Amrita saying no flap. Subbu is going to get real wild with you. How do you decide?
Sir, based on how much tongue we are resecting, if we are resecting less than 1/3 of tongue, maybe we can get away without putting a flap.
Okay, lovely. Everybody agrees with that?
Yes.
Yes, sir.
Yeah, so it's not only the tongue, the volume, it also depends on where this is located. If you're taking out a lot of the floor of the mouth by turning the tongue, you're going to tether the tongue. In that case, you may want to put a flap in as well. But generally, I agree with you, the dictum is 30%. Anything less than 30%, we don't close. But sometimes we can even stretch a little more and, close. It depends on patient to patient. So don't come with your vernier calipers and measure and say exactly 30, 1/3 is gone, and that's why I want to put a flap. You need to use your judgment. Any of y'all, this is my gold medal question. It just struck me. Any of you aware of volumetric assessments of tongue on MRI? Assess the volume of the tongue, 30% of the tongue gone. Okay, I'll tell you what percentage or what volume of tumor will cause metastasis. We all know about 4 millimeters. What volume will cause metastasis? Okay, I'm not going to waste time. There's a guy called Vincent Chong in Singapore. Google his name. 13 cc volume has a higher predisposition for metastasis. And also you are able to do some sort of reconstruction to assess volume. He is a radiologist. He has not told you to do reconstruction on that, but there's enough work there to assess volume to pre-operatively tell you whether you need to reconstruct or not. Akshat, I'm a good examiner. Exactly 45 minutes I'm handing back to you. Any questions from the young panel? You guys were great. I sometimes say that if I had the knowledge at your age, I would be a great surgeon. But anyway, Akshat, back to you.
Unfortunately, sir, Saurabh here, sir. One question for my side.
Bol Saurabh. Saurabh always troubles me, incidentally.
No.
I'm your guest today. I'm not from the Delhi Head and Neck group.
So just want to learn, sir. Always I learn from you. Sir, what is the in the N plus neck? What is the indication to doing a level 5, or you will not do the level 5 in N plus neck? And when you will not do the level 5 N plus?
The N plus neck level 5. Who do I quote for that? I think there's a nice 5 article meta-analysis,
Yeah.
43 patients showing that the supraomoid is as good, and there's the Ferlito group review of all literature. I forget the first name, but Ferlito is Alfio Ferlito is the last name, looking at everything. So basically, I'll tell you, if you have a small node at level 2, a small node, 1, 2, and 3 is good enough. If you have a large node, then 100% you will do a comprehensive neck dissection. Now, it's not sacrosanct that you have to do this policy, but generally, an upper neck dissection is safe even for a very early metastatic disease in the upper neck. So if we looked at Gauri's paper, the thing when we discuss it, it did not tell us the size of 2A node to predict 2B and 5. But my judgment as someone treating head and neck, if it's an occult metastasis at 2A, it's unlikely to seed 5. So in those cases, I won't go gung-ho to operate on 5. Remember, most of your problems with your shoulder is the accessory nerve at level 5. It's thin, it's very easily damaged, it's very easily pulled, giving ataxia, and all shoulder dysfunction is because of that.
Thank you, sir.
I can send you the 2 references if you want, because I use these very often when I speak.
Thanks. I will.
Thanks a lot for the lovely class. I know there'll be more questions pouring in, but then we'll have to move on with the next part.
Thanks for having me, Akshat. Thank you very much. I enjoyed it.
Thank you, sir.
Privilege for us, sir.
And I want to say that the guys who presented were very good. Huh? Congratulations. You all would have really been up there fighting for the gold medal finally. Good. Thank you. All the best to you all in your exams.
Thank you.
Right. So now we'll move on with article appraisal, where we have Vibhe Parekh from, he's a radiation oncology resident from AIIMS, who will be presenting article RTOG 1016. How we'll be doing this is, like, we'll give 15 minutes to Vibhe to present the article. And after that, we have got 3 experts, Professor Atul Sharma from AIIMS and Dr. Manish Goyrala. He's Director Radiation Oncology at Rajiv Gandhi Cancer Institute. And Dr. Rajiv Sharan, he's a senior head neck surgeon at Tata Medical Center, Kolkata. So these 3 experts, we'll give them 5 minutes each at the end so that they can put their take on this article and other treatment de-escalation related articles. So over to you, Vibhe, so that you can start off.
Good evening, everyone. I would be presenting the RTOG 1016 paper. The publication had come out in the Lancet Oncology. It was published in November 2018 with a corrected version that came out in March 2020. So what was the need for the study? Now, we all know that HPV, the virus, it's an established causative agent in the oropharyngeal malignancies, and the incidence is increasing across the globe, especially in India. When the paper came out from the group in the RTOG 0129, they said that the prognosis is better in the HPV positive subgroup of the oropharyngeal malignancies, where the 3-year survival was 82 versus 57%. Also, one of the concerns that is there in such a disease state is that the late treatment toxicity with the improved outcomes and the young age of diagnosis. So what was the concern related to? Now, chemotherapy, which is added to the radiation therapy, we know that there is an 8% absolute 5-year benefit, which was shown in the meta-analysis of chemotherapy in the McKinsey trial. So it was the cisplatin which showed moderate to severe toxicity. It showed severe dysphagia, the feeding tube dependency, or the death, which was in the tune of 43% at 3 years. Then came the Bonner trial that used cetuximab, which is an EGFR antagonist. It showed that the 5-year survival benefit was 9.2%. Similarly, Rosenthal et al. In the IMCL 9815, they said that there are similar benefits for the oropharyngeal malignancies when you're using these EGFR antagonists. However, till date, we did not have any trial which compared cisplatin with cetuximab. So the RTOG 1016, it was a randomized non-inferiority multicentric trial which was conducted across 182 centers in the US and Canada. The eligibility criteria included HPV positive oropharyngeal malignancies. They were staged according to the AJCC 7th edition, including the T1, T2, N2A, N3, or the T3, T4, N0 to N3 disease. The Zubrod performance score, it was important in their analysis. 0 or 1 ZPS score was taken into account. The patient needed to have an adequate bone marrow, renal, or the liver functions. The patient gave a written informed consent and ethical clearance was taken. Randomization was through the randomly permuted blocks, which was stratified by the T or the N category with the ZPS scoring as well as the tobacco smoking. The randomization was in the tune of 1:1, where the patients were, they either received cetuximab or cisplatin with radiation therapy. So this is the randomization. The cetuximab loading dose was 400 milligram meter square, which was given 5 to 7 days prior to the RT start, followed by 250 milligram per meter square weekly for 7 doses, to a total dose of 2,150 milligram per meter square. Cisplatin was 100 milligram per meter square on days 1 and 2, or 1 and 22 of the radiation therapy, to a total dose of 200 milligram per meter square. Radiation was same in both the arms. It was an accelerated IMRT, 70 gray in 35 fractions for 6 weeks, that is 6 fractions per week, with 2 fractions given on day 1, which was 6 hours apart. For the other procedures, the testing for the HPV was done in a in the central laboratory. The IHC was done for P16 expression. The lifetime cigarette exposure history was taken at the enrollment via standardized computer assisted self-interview, and the quality of life outcomes were assessed at the baseline, at the end of treatment, and 3, 6, and 12 months after completion of treatment. The outcomes were in the term of the primary and the secondary endpoints. The primary endpoint included the overall survival, that is time from randomization to the death from any cause. Secondary endpoints included the progression-free survival, the loco-regional failure, as well as development of distant metastasis, development of second primary tumors, and the adverse events were divided into acute and late, that is acute being less than 180 days and late being more than 180 days. Early deaths were also included, that is deaths due to any adverse event or within 30 days of treatment completion. Dental health was assessed through the Likert 5-point scale, and the quality of life was assessed for the limited patients, that is the first 400 patients, with the use of the EORTC questionnaire. Only the swallowing parameter was taken into account. The CTCAE 4.0 was the parameter used for looking into the adverse events. The scoring was done at the baseline, once per week during the radiation, end of radiation, and at 1 and 3 months after treatment completion. So this is the consort diagram. A total of 849 patients were randomized into the 2 groups, either receiving cisplatin or cetuximab. In the end, there were 406 patients in the cisplatin group which were analyzed, and you had 399 patients who were analyzed for the use of cetuximab. So the initial investigation, the patients who were receiving RT plus cetuximab, the 5-year OS was taken into account through the RTOG 0129, and the non-inferiority that was shown in that paper of 9% was taken into consideration. And after defining the power at 80% with a one-sided alpha of 0.05, the number was set at 600 patients. However, in 2013, when the RTOG 0522 came into picture, which showed reflected a higher survival, especially in the P16 positive oropharyngeal malignancies, there was a change in the HR values, and a non-inferiority margin of 1.45 was set, with a smaller absolute difference at 5 years of 7.6%. So considering the attrition at the rate of 20%, a total of 1,000 patients were expected to be enrolled in the duration of 8.15 years. The primary analysis was an intention to treat basis, and if the upper limit of one-sided 95% confidence interval for the hazard ratio was less than 1.45, it was said that the non-inferiority would be met, and the results would be declared open by the NRG group. The overall survival and the progression-free survival were calculated using the Kaplan-Meier method, and comparison was done with the log rank test. The loco-regional failure, distant metastasis, and the second primary development, the cumulative incidence functions were taken into account, and the outcomes were calculated using the specific log rank test. For the calculation of the toxicities, for the acute toxicity, we had the T-score, and for the late toxicity, we had the A-score, which were calculated using the TAME method. So now coming to the results. Now the study, the enrollment started in June 2011, completed in July 2014. A total of 987 patients were enrolled and 849 patients were randomized. 399 in the cetuximab group and 406 in the cisplatin group. Predominantly, the patients were males and belonged to they were whites. The median age was 58 years. The mean dose of cetuximab was 1940 milligram per meter square and cisplatin was 184.7 milligram per meter square. RT, which was completed per protocol, it was in the tune of 86% in the cetuximab group and 83% in the cisplatin group, so it was quite well matched. The median follow-up was for 4.5 years. So here we can see the patient and the tumor baseline characteristics, where the majority were males, they were whites, and among the oropharyngeal sites as well, if you look into the subsites, the majority constituted the disease in the tonsillar fossa or the base of tongue. Similarly, when the nodal category was looked into, it was the N2B stage, which was the majority. So the overall staging, around 93% of the patients were stage 4. So now coming to the results. Now the overall survival in the study, it was found to be worse with cetuximab and it was statistically significant, favoring the cisplatin use with a p-value of 0.0163. The estimated 5-year survival, it was found to be 77.9% with the cetuximab arm versus 84.6% in the cisplatin arm. When they looked into the ZPS score, the Zubrod performance score of 1, it was significantly worse with cetuximab with a hazard ratio of 2.66. However, it was not significant with the adjusted when it was adjusted for multiple comparisons. Similarly, when you look into the progression-free survival, it was significantly favoring the cisplatin arm with the cetuximab showing a 5-year PFS of 67.3 versus 78.4%. Again, there was a larger difference for the performance score of 1. The risk of locoregional failure in cetuximab was more than twice with the hazard ratio of 2.05. The 5-year locoregional failure, if you look into the quantitative assessment, it was 17.3 versus 9.9%. There was no difference in the distant metastasis development with the tune of the 5-year proportions being 11.7 versus 8.6%. The second primary tumor recurrence, again, it was same in both the groups. Coming to the adverse events, the events were quite similar. It was 77.4% versus 81.7%, slightly favoring the cisplatin arm. Among the various common toxicities that were developing, in the cetuximab arm, we had the acneiform rash, whereas in the cisplatin, we had the myelosuppression, anemia, nausea, vomiting, as well as the other common toxicities, that is the kidney injury and the hearing impairment. When the acute toxicities were scored using the T-score, it was lower in the cetuximab arm with 2.35 versus 3.19, which was statistically significant, favoring the cetuximab arm. Comparing the late toxicities, it was similar and not statistically significant. There was no difference in the grade 3 and 4 adverse events at 1 year, with the adverse event score being 8.5% for the cetuximab versus 10% for the cisplatin arm. When the feeding tube placement at the treatment completion was looked into, it was quite similar, slightly favoring the cetuximab arm, and over 1 year completion, it was more or less similar in both the groups. So now coming to the discussion, now in what this study actually provided us was that the RT plus the cetuximab arm, it showed an inferior overall survival and an increased risk of cancer progression, death, or the local regional failure. Now cisplatin, it did develop a greater overall burden of acute toxicity with a higher T-score when it was compared with the cetuximab. It was the first study which looked into the toxicity amelioration or the treatment de-intensification in the HPV positive oropharyngeal malignancies. So this trial was actually based on the findings of the RTOG 0129, the RTOG 0522, as well as the IMC 9815. So we had the accelerated RT for 6 weeks based on the RTOG 0129. And the role of cetuximab showing an improved survival without increase in the quality of life detriment. It was based on the IMC 9815. So they concluded that cetuximab is less effective than cisplatin. So what do we see in the literature? Now, there was no randomized trial which was actually comparing cetuximab with cisplatin, but we have a lot of retrospective studies, especially the study by Nadeem Riaz's group, which looked into the comparison between cetuximab and cisplatin, along with the other studies from the Canadian as well as the US group. All these studies, if you look into, they all favored the cisplatin arm, and we can see the 3-year loco-regional control as well as the distant metastasis-free survival, the recurrence-free survival. All these parameters were favoring the cisplatin arm as compared to the cetuximab arm. Is there any other EGFR which has been looked into? So we have the CONCERT 2 results which have come out. It's a randomized controlled open label phase 2 trial which looked into panitumumab versus the role of cisplatin. Again, the group concluded that panitumumab cannot replace cisplatin in the combined treatment with radiotherapy for unresected stage 3 or stage 4B SCC of the head and neck. Similarly, this was a randomized phase 2 trial which looked into cetuximab and radiotherapy versus cisplatin. The results, again, they said that the efficacy outcomes were similar in both the arms, but you needed a better RCT to define. In this meta-analysis by the Yuang group, Yuang et al., they recommended that further RCTs are needed to be determining the utility of cetuximab in the head and neck squamous cell carcinomas, especially if you're looking into the oropharyngeal or the HPV positive specific subgroups. So coming to the limitations of this trial, it did not select for favorable risk groups. There was no difference that was defined or set for the Zubrod performance score of 0. P16 expression was done by IHC, so you could have almost 20% false positivity that would be seen. There was the estimated hazard risk that was set at 1.45 and the upper limit set for the hazard ratio confidence interval. It was too conservative and needed to be looked into. Again, the cisplatin that was given, it was given in the tune of 100 milligram per meter square at day 1 and 22, which does not go very well with the conventional 35 to 40 milligram per meter square that's given weekly. So to conclude, radiotherapy, the group concluded that radiotherapy plus cetuximab, it did not meet the criteria for non-inferiority for the overall survival, and it established that the cisplatin is to continue as a standard of care. So the strategies to improve 5 years of progression-free survival achieved with radiotherapy with cisplatin, it's to reduce the toxicity, and we need for further trials that need to look into these subgroups, especially in the HPV positive oropharyngeal carcinomas. So the take-home message, with the established role of cisplatin, we should first have a primary goal as to be doing no harm to the patient. We do not need to put the cart before the horse. Long-term data would inform on downstream consequences of the early local failures, on the rate of distant metastasis in this trial, especially also the other trial, the de-escalation trial that had come. We have excellent outcomes with RT and cisplatin. The NRG HN002 results have come, which will now open the floodgates for the role of de-escalation in RT. And but still, we do not need to get blinded with the de-intensification treatment. Thank you.
Well, thank you. That was a very elaborate and good presentation. We'll move on with the expert comments, and we would start off with none other than Dr. Atul Sharma. Sir, if you'd like to put in a few words regarding this article as well as otherwise for de-escalation strategies.
All right, thank you very much. So I think Dr. Parikh, nice coverage, and probably you really did justice to the article. So a couple of quick comments while I was reading about this thing and this thing. So what we have learned over a period of time, so we leave beside this thing RT0129 for its time being and this thing. So what we have the number of evidence, we have 1, 2, 3, and possibly one phase 2 randomized trial which suggests that cetuximab may be inferior to cisplatin when we combine with this thing, the radiation in the head and neck cancer, mainly HPV oropharynx I'm talking about. So we RTOG 1016 we had discussed. Now we have the result from the de-escalate, which was published about a year ago. We have a result which was published last couple of weeks ago, ART-SCAN trial from the Sweden, which suggested the same finding. So conclusion for all the 3 studies and one Italian study, which probably Dr. Parikh was alluding to, more or less the same, that for the partner, cetuximab is not a good partner with the radiation when combined for the head and neck cancer or HPV oropharyngeal cancer. The possible reasons about that, we have been getting some kind of this thing, because always we are either in the hindsight. If you see the RTOG 0522 study, so when addition of the cetuximab did not improve the outcome, and in fact that was not really that was worse. We also have some evidence that with HPV-16 or HPV positive and HPV negative, these are the two different, genetically different oropharyngeal cancer. Now we are getting some preclinical data which suggests that in the HPV positive tumors, what happens is that the mutations downstream this thing, EGFR level receptors are there, so that probably it induces it is resistant to the cetuximab. Not only that, we are getting some kind of the indication from the various preclinical studies, and these are the thought-provoking studies, which suggest that probably at least maybe that cetuximab might be inducing some kind of radio resistance to these tumors. They say it is because probably part of the cetuximab is effective through the activation of the innate immunity, and possible that when combined with radiation, it has altered the local tumor or immune microenvironment. So this is the hypothesis generally, but what we know for sure for the time being is that the in HPV positive tumor, radiation and cetuximab lead to poorer outcome. And by the way, probably, and this poorer outcome is not because of the failures at the distant site or elsewhere. This poorer outcome is because of the failure at the local regional areas. One can argue that maybe the radiation techniques were not great, but obviously you see the RTOG and this thing de-escalate and the ART-SCAN trial, all these things, they have used the IMRT and the robust radiation technique. And if you recall the meta-analysis, McKinsey analysis previously and the current one which was published last month only, the survival advantage with the cisplatin in head and neck cancer is because of the reduction in the locoregional failure. So that is the survival advantage. So we need to accept that probably for the time being, unless we have new evidence of this thing, cetuximab and radiation is inferior to cetuximab, cisplatin and radiation in head and neck cancer in general, and oropharyngeal HPV positive oropharyngeal tumor in particular. So I quote even, I think there have been lot of this queries and comments written about these three studies. I just quote one commentator's also idea about the desire to de-intensify treatment for HPV positive oropharyngeal tumor should not blind us to the excellent outcome we currently achieve with 70 GY and cisplatin. And mind you, most of these studies have used the patient in the tube with the performance status 0 and 1. And most of our patients will be the performance status 2. And it has clearly shown that even with the ECOG 1, the outcome is poorer. So we don't know what will be the outcome in the ECOG 2. Thank you very much. Maybe that Monish can add to the comment. Or this.
Great, sir. Thanks a lot. Very nice observation by you. And Dr. Manish, can you, are you around? Sorry, you are muted, I believe.
No, it's okay now.
Yes, yes.
So, yeah. Good evening. Thank you. Thank you, Dr. Atul, for summarizing everything. For me, as far as we all know that HPV positive oropharyngeal primaries are considered as a distinct entity and from the HPV negative head and neck cancers and with superior outcome. So for us, therefore, our entire treatment de-escalation philosophy is based on 4 strategies, which I believe that first is use of induction chemotherapy and that using response-dependent radiation. Another was reduced IMRT plus concurrent chemotherapy doses. Third was, as Dr. Atul mentioned just now, that replacing cisplatin with cetuximab. And the fourth was, in de-escalation process, was using minimal invasive surgery followed by risk adaptive radiotherapy. As Dr. Parikh and then Dr. Atul mentioned very clearly that cetuximab doesn't work in HPV positive patients. Both RTOG 1096 and de-escalate trial, they support this finding and support the notion that, outcome for HPV positive oropharyngeal patients strongly depend on type of treatment they are receiving. That is the most important thing. Another few trials which I wanted to highlight in this regard, they are like Optima or E1308, and many more have addressed the use of induction chemotherapy to reduce radiotherapy dose. Mostly they are the phase 2 trials and have started good local control and better quality of life in these patients. Since all these studies, those who are observed that chemotherapy arm, which was in de-escalate trial, was there, and the findings were more or less same. But the question remains unanswered that if it is worth to trade full dose of induction chemotherapy toxicity and its induction toxicity for reducing 60 to 20 gray of radiotherapy. That was the major question, and which was, comes in our mind before giving induction chemotherapy and then lesser dose of radiotherapy to de-escalate the dose of radiotherapy in HPV positive patient. Also, it was worrying that, that just by reducing dose of IMRT in low risk group especially may affect the local regional control rates as well. So even though Dr. Parikh has mentioned the recently published trial NRG HN002, which was published now in JCO February 2021 issue. So they state that reduced IMRT without chemotherapy is suitable for low risk HPV positive patients. But when you go in detail of this trial, so there are a lot of issues with trial design and methodology, which I think we should always discuss before deciding or before inferring anything about this. Another thing which I would like to mention here, that ECOG 3311 promising phase 2 results showing advantage of minimal invasive surgery followed by risk adaptive radiotherapy. For those where the margins are uninvolved, less than 5 lymph node, and minimal, that means less than 1 millimeter of extranodal extension was there. There they have used a reduced dose of post-operative radiotherapy in the tune of 50 gray without chemotherapy, which was as good as using chemotherapy. However, phase 3 trial data is required to confirm this observation, and we all know that the ongoing trial lies like PATHOS trial, which is the results are still awaiting. They are underway, and with the publication of this trial, we may be able to know the dose of radiation in post-operative setting. So finally, would like to say that a question in this backdrop of backdrop that we figure out, and are there are two questions which come in my mind in final this thing, that which subset of HPV positive would benefit with the trial of de-escalation of chemo radiation dose. That is also a big question. Another thing is which we have discussed this question so many times in head and neck forums, and again I am posing this question, that are Indian HPV positive similar to sample population in the trial done in the West, considering that we have majority of population with unfiltered smoking and more concurrent P53 mutation seen in our patients, which we all know that P53 is as such, it's a bad prognostic feature, independent or irrespective of HPV status. So these are the questions. I think the answer of both of these questions remains largely unanswered, and we should always, try to answer this question. With this, I would like to conclude my this observation or my take on this article trial. Thank you, Dr. Akshay.
Thank you, sir. Thank you. Dr. Sharan.
Good evening, everyone. I'd like to thank Akshat for giving me this opportunity. So this was a very wonderful presentation, and a lot of medical cetuximab and cisplatin have been covered. So surgical point of view, TORS, transoral robotic surgery has come in a big way, and a lot of retrospective and prospective studies along with meta-analysis and systemic review all have shown that TORS is equally has equivalent oncological outcomes with improved functional outcome. So different studies by Almeida et al. And all that have shown that survival is equivalent to non-surgical treatment for HPV positive oropharyngeal cancer. So I will be just discussing few surgical trial based on like that all includes surgery, minimal invasive surgery in the form of transoral robotic surgery. And first important trial that was randomized phase 2 trial was Orator trial, and that comprises of only 68 patients, and they showed that swallowing related quality of life was superior with radiation than transoral robotic surgery. But this difference was not clinically meaningful because they kept as 10 points different for clinically meaningful difference in swallowing related quality of life. So maybe like future phase 3 trials will answer this question. So another trial is ECOG 3311, and that included transoral robotic surgery with neck dissections, and based on pathological features, they were randomized in different groups based on risk features. So low risk, they didn't give any adjuvant therapy. For intermediate risk, for close margin or less than 1 millimeter of extracapsular, they gave 50 gray of radiation versus 60 gray of radiation, and they found that both the arms were equivalent. So 50 gray was was sufficient for this group for as a adjuvant treatment. So this study was presented in ASCO last year and published in ASCO JCO in the abstract, and they have shown that survival is equal. So we can de-escalate adjuvant treatment after minimal invasive surgery in the form of transoral robotic surgeries. So another trial is ADEPT trial, again that includes transoral robotic surgery with neck dissection, and if for HPV positive cancer, oropharyngeal cancers, and if extra nodal extension was present, then that was randomized into either radiotherapy or concurrent chemoradiotherapy. So still results are awaited. And PATHOS trial, as mentioned by Dr. Moniz, already covered. So again, almost similar to ECOG 3311 trial, and results are awaited. And one interesting trial that was phase 2 single institutional study by Weinstein group, that was a VOID trial. So they gave adjuvant treatment based on risk neck sites. So if primary sites was favorable, no adverse features and did not require radiotherapy for primary site, and if patient required radiotherapy due to the neck nodes, so in that case they gave radiotherapy to the neck and avoided primary site in the radiation plan, and they showed loco-regional free survival of almost 98%. So this is this may be important because a lot of time primary site doesn't require radiation, but due to high risk features in the neck, patient requires adjuvant treatment. And if you can avoid radiation to the primary site, then a lot of treatment related morbidity can be decreased and patient may have better quality of life. So a lot of trials results are awaited, and all once these results come, then obviously that will guide us in taking treatment decisions for our HPV positive patient. Thank you.
Thank you, Dr. Sharan. Thank you. So why we wanted to do it this way was because we wanted perspective from all three aspects: the medical oncology, radiation oncology, as well as from the surgical oncology side. I hope all these perspectives as well as the article itself was useful for the trainees. For the next session, I would like to ask if Dr. Alok will invite our next speaker. Meanwhile, for this, I'd like to thank Professor Atul Sharma, Dr. Gairola, and Dr. Sharan for this session.
So good evening, Win. I can see you've been around for a while, awaiting your turn, but I'm sure you're witness to the fantastic program that's been put forth by Akshat and Smriti and Gagan here. And of course, you've seen the high standards being set by our trainees. So my job is to introduce you. The cliche goes, you need no introduction. But if our trainees are well read, then certainly you don't need an introduction. Because Professor Polari has actually contributed to, I think, a large majority of the relevant literature today. So his USP is not that he has got a lot of publications out there, but I would say that his USP is that he's got a lot of relevant publications out there. I love what he writes, and I'm sure so do you. He has taken the path of identifying the right questions to be answered and found answers to those questions. Were they by looking at the literature, or were they by setting up new trials to sort those questions? And indeed, it's been fantastic to see his growth over the years. He was initially trained at JIPMER, so of course many of us choose to call him our own. And of course, when I was in JIPMER a little bit recently, then everybody takes pride in having Win as their own. When I go to Kerala, I find that everybody takes pride in having Win as their own. And of course, so do I take pride in having him as a friend. So Win today is going to speak to us about the iKnife. And we thought that in this session, we would look not only at the science of what we do, but also a little bit at the craft and technology of what we do. So Professor Polari, who is currently at the Royal Marsden, will tell us about what he's doing with the iKnife and why he's excited about it. So thank you, Win. And may I request Akshat and Smriti to take it from here and ask Win on any questions that may come up to their minds after this.
Sure, sir, sure.
Thank you, Alok. Thank you for the kind introduction. That's hopefully, and I feel very much part of the Indian head and neck community. And every time I come there for meetings, it's just phenomenal to be back there. Sadly, the Kerala meeting had to be postponed. The face-to-face meeting had to be postponed because of COVID. But I hope with the second wave, we all are well, and I hope your families are well, more importantly. And I feel for you. My heart's there when I think about the news that's filtering out from India. I wish you all the best. Greetings from Oxford. I'm actually in Oxford today, doing something else with another team. Thank you for inviting me to speak on this. So I have to preface this by saying that this is early phase data, what I'm going to present. It isn't as robust as you'd like it to be. I mean, I've been blown away by the quality of the scientific discussions over the last 30 minutes I've been sat here. I think it's phenomenal what you guys do in India. It's a shame that I couldn't participate in a greater proportion of this. So let me share my screen, and then I can spend the next 15 minutes speaking about iKnife and why we are doing what we're doing. Can you see my screen?
Yes, sir, we can.
Thank you. So Akshat, thanks for asking me to speak on this topic. This is something we've been working on over the last couple of years. So let me put things in perspective as to where we started, how we got here, and why we are doing this particular piece of work. I have a conflict in that I'm a proctor for Intuitive, so I had to be open and say that I do help them with proctoring, and that's what I'm doing here today in Oxford. I'm helping them with the recurrent tonsil cancer being resected transorally. So what's the premise behind the iKnife? Essentially, so this goes back to Otto Warburg. Otto won the 1931 Nobel Prize in medicine. He actually was a physician, he did internal medicine, and he worked in the lab, and he showed that when it comes to cancer, cancer metabolizes glucose by the relatively energy inefficient process of glycolysis. Even when cancer cells have oxygen, they use glucose differently, and they don't perform oxidative phosphorylation. It undergoes glycolysis, and this is called aerobic glycolysis. So which is why when you perform a PET-CT scan, cancer picks up so much more activity using the FDG PET scans, because FDG labels FDG label helps the glucose activity to be picked up quite nicely. So when cancer cells do this, what does happen is when they use so much glucose energy, they seem to somehow modify their protein and lipid structure within them. And that's what leads to a different lipid profile for cancer cells compared to normal cells. And this is what the iKnife is trying to exploit. So the hypothesis is that by using a different glucose intensive process for energy, the lipid profile within the cancer cells, perhaps they redirect more lipids to structural entities like the cell membrane and take away lipids from other activities, which means that the profile for cancer cells is different compared to normal cells. And this is what we're trying to capitalize on by using the iKnife. And we know that based on the lipid profile, you can recognize tissues. For instance, when you're at a barbecue, it's a great season for barbecue here. So whether it's chicken on the barbecue or lamb on the barbecue, you can make out by the burning meat what kind of meat it is. And that's exactly what the iKnife is doing, but in a much more precise fashion. So here's a little video to show you what we do in this setting. I hope this plays. Okay, so that is monopolar cautery. So that's cutting through tissue. The smoke is sucked up the monopolar cautery. And then this is fed into the iKnife. I'll explain what exactly happens there. The vapor is taken into a mass spec machine. And within the mass spec machine, it is mixed with an alcohol solvent, isopropanol alcohol. So the matrix of the IPA, it sucks in some medical air as well. It runs it past a hot electrode, and just like a carburetor, it separates it. It's ionized and filtered and measured by the mass spectrometer. So what is not needed is filtered. What is needed is taken up the mass spectrometer, and then the mass spectrometer then utilizes the stored algorithm to define what exactly is going on in the smoke that is sucked in. Let me put some more information on that particular piece of information. So this particular slide shows how it's done. This, for example, is breast cancer. So we're using an electrocautery unit to cut through the tumor. And within the tumor, what happens is we're sucking away the aerosol and into a mass spectrometer. After we ensure that we are cutting through cancer, we confirm it's cancer, the mass spectra is then used to train a prediction algorithm. The algorithm will then subsequently distinguish between smoke from the cancer and smoke from non-cancer. The training is done repeatedly, so the algorithm is quite well defined, and we can then create a program to tell us cancer from non-cancer within a second. So the ambition is that the surgeon is offered real-time biochemical feedback to avoid a risky positive margin. That's a big aim here. So we suck the smoke, run it through a mass spec machine. The mass spec machine then compares what is being analyzed to its predictive algorithm and rapidly gives you an outcome, whether we're cutting through tumor or non-tumor. And this has been shown to be quite effective in breast cancer, and that we're now working on head and neck cancer here. So this is what the external interface of the mass spec looks like. So moving clockwise, if you can see my mouse, the corrugated tube here is exhaust plume that is going out, that's sucked, that is the waste plume that is not needed within the mass spec machine. The pink one, red one here, the pink one here is the IPA. The alcohol is used is mixed with the smoke that is sucked in to create a matrix for analysis. The black tube here is just air, medical air, which is just used in the mix. And the plain tube here, the transparent tube here, is what takes the smoke away from the tumor into the machine. So these are the four entities that lead into the iKnife machine and then gives us the data we need to have. So we've done this work on, again, this is not my work, I have to emphasize, this was done by my current PhD student, Jim Higginson, under the supervision of Andrew Shackey in Liverpool and Jack Dander in East Grinstead. So this was done on 74 patients with matched tumor, fat, mucosa, and muscle, and we then cross-validated it. And we can obtain, using clever statistics, an overall diagnostic accuracy of 97.7% in the discriminant analysis. So the basic data, the lab data, the in vitro data is superb and allowing us to distinguish between tumor and non-tumor tissue. And therefore, we thought we should take this further into in vivo analysis. So where are we now with this? We know that the spectra are distinguishable. Normal tissue looks different, looks fundamentally different to tumor tissue. And interestingly, whether we use laser or whether we use diathermy, it doesn't seem to matter. The sensitivity and the specificity of ability of the iKnife system to distinguish between different plumes appears to be intact. So we thought, we got this fantastic data coming through. How can we use it best? We can use it on primary cases. If you use it there, most primary patients have a radiation safety net, and then it becomes difficult to synthesize the evidence after that, because if some of them have radiation, then we don't know how much of the effect the radiation had in controlling disease. So we thought we should look at recurrent cases alone. And we've been working on recurrences in oropharynx cancer for a while now. And we know that in the setting of recurrent tumors, salvage surgery is a good thing to do, whether it's residual tumor or recurrent tumor. We know from good data from patients who have been randomized to radiation oncology trials who recur subsequently, salvage is good where feasible. And salvage leads to 50% plus reduction in mortality in that setting. So we looked at systematic review first. This is John Hartman, my PhD student. And these are surgeons, ladies and gentlemen. These are surgeons who take time out of surgical training to spend time doing research that leads to a PhD. So we first thought we look at the systematic review. We looked at the data published, and we went through the usual PRISMA guidance. And the bottom line is that we found 161 cases where TORs are being used for salvage surgery. And we found that the 2-year overall survival was pretty decent for 74% plus. So we thought this is pretty positive, it's reasonable, but then clearly published data from retrospective cohorts has inbuilt bias in it, and you can't really hang your hat on it. You can't depend on this kind of data completely. So we thought another piece of work was warranted. We needed to do something more to try and get a further handle on this, on the efficacy of robotic surgery for recurrent cancer, because it's a new and emerging indication. So we set up the RECUT study. The RECUT study is transoral robotic surgery for recurrent tumors of the oropharynx mainly, but this was an independent and individual patient data meta-analysis. So we're not looking at just published data. We're going back to centers and asking, have you got patients you treated with TORs? And when did you start? Can we have the consecutive list of patients? And then we want to know what the latest outcome for each patient is, both oncologically and functionally. So we're not asking for a convenience cohort. Some centers will just publish the successful patients. Others may not. So we wanted a very clear methodology, and these patients were being followed up. And the minimum follow-up we wanted was 2 years. So we went through, this has been going on for 3 years now, and we now have decent data. I think this is probably the first informal airing for the data. So RECUT study involved 16 centers. As you can see, there are 2 from India. One is Tata Memorial, and the other one is BLK, Super Specialty Hospital. So the lead investigator at Tata Memorial is Gauri Pant Vaidya, and the lead investigator at BLK is Surinder Dabas. So we now have data on this, and we have had 306 individual patient data sent in. This table needs a bit of updating, but the total number is 306 patients. So let's look at the survival and oncological outcomes. We looked at this very carefully, and it looks like we're getting 50% plus survival at 5 years when you perform TORS on a select number of T1, T2 cancers. The vast majority of cancers are T1, T2 cancers, understandably, and that's what TORS is approved for. So in the recurrent cancer setting, TORS is clearly an acceptable and good modality. So we thought, what if we use iKnife in this particular setting? So in our hands, TORS is a robust modality to treat recurrent cancer. And in comes Jim Higginson. Jim's a maxillofacial surgeon, again, taking time out of his surgical training program to perform a PhD. So we applied to NIHR, got a grant for £500,000 to support Jim and to perform this piece of work. And let me explain to you what exactly we've done so far and what the background is. Again, coming back to methodology, like the previous trials you discussed, the 1016 and the 0522 and the IMC trials, methodology is everything. If you want people to look at your results and change practice based on results, you must have a robust methodology. Clearly, these can't be phase 3 trials, so these are earlier trials. But when it comes to earlier surgical interventional studies, try and look at the ideal collaboration website to define and design your trials. So this is a framework, ladies and gentlemen. It's a framework put together by surgeons, by methodologists, by statisticians, by researchers to help us come up with a good way to perform surgical studies. So depending on which phase, which part of your surgical pathway you are in, you can drop into phase 1, 2A, 2B, or 3 or 4. So this particular entity, the study I'm discussing, the iKnife study, fell into the 2A design. So what we're trying to do here is to rapidly and iteratively modify the technique and indications for this particular use of iKnife in the recurrent cancer setting. And our focus was on technical details and feasibility with limited numbers from one center. So we got the money for this, and we set this up. I'll explain to you what happens in theater, but at this point in time, we've recruited 7 patients, and we've certainly gone above our proposed recruitment target, which is pretty good. And our aim is twofold. The first aim is to confirm that the predictive algorithm is valid when we try to distinguish between tumor tissue and normal tissue. And our gold standard here is histopathology. And secondly, we want to generate a protocol that allows a reliable and robust capture of the smoke signal throughout the procedure, even when operating transorally in the oropharynx or the hypopharynx. So this is tricky. It took us a while to get this right. And we could write this up at some point, but this we're getting pretty robust signal all the way through the operation. Let me show you an example here. This, for example, is a signal. This is 7 patients. You can see the signal at the back. The signal is pretty robust. So in theater, we have Jim, the PhD student. We have a physicist helping out to ensure that we have good data coming through, because if anything goes wrong with the iKnife kit, it's quite a big piece of kit, then we need a physicist to try and sort it out. Sometimes the IPA runs out, and we have to go and bring some 100% pure IPA and bring it back in and plug it back into the machine. But the data we're getting after all the things we've done to set it up is looking pretty good. The machine is bulky and noisy. It has to be moved into the theater the previous evening, but that's the only way it will work, because it has to be, the vacuum has to pump it down to make sure it works the next morning. But patients are happy to proceed. There's good engagement from the theater team, and interim analysis is underway, but our analysis indicates that the data we're getting is good and seems to marry up with the algorithm so far. So in theater, you can see the iKnife machine right at the back. That's a black piece of kit. It's stuck in the corner. TORS going on, and there is a tube that goes from inside the patient's oral cavity. So one of the suction Yankovic tubes is used to suck, is used to retract, and we don't connect a sucker to that. And we try and minimize bleeding. If bleeding happens, we try and use diathermy, but all the time we have another sucker that is collecting smoke from the tip of the energy instrument, taking to the iKnife machine. And this is a medical physicist, FT here, who's standing there and ensuring the signal is pretty good while the others are helping out with the procedure. And clearly, this is a feasibility piece of work. It's an early stage work. We can't just limit ourselves to the surgical aspects. A lot of future work planned around this as well, around the eye knife. So it's not just a black box. So the spectra, we think we can biologically correlate this with a lot of actionable information about the phenotype of the tumor being resected in this setting. For example, last year, Zoltan Takas, who's the biochemist whose brainchild this is, they demonstrated that the signal from iKnife was able to differentiate between ER positive tumors and ER negative breast tumors, which is pretty good. So alongside this work, our plan is to work and define some of the additional biomolecular mechanisms that underpin the algorithms. For example, we're going to use mass spec to try and define the lipid differences, lipid species differences between HPV positive and HPV negative tumors. We're also going to work on a spatial analysis piece of work to define the tumor phenotype on the tumor sample. So what we can do is we can use a tightly rastered pattern of laser to ablate tissue and then define a heat map of the tumor, and then tell us how much of tumor is at the margin. If we can use REAMS alone, iKnife alone, to define the margins during resection. So there's a lot of work going on in the background in the lab for in vitro studies as well. Just to finish off, this is not just a one-person thing. Clearly, there's a lot of work going on in the recurrence field within our center. The RECUT Plus studies look at clonal evolution within the same tumor that's resected. Ben O'Leary is an oncologist working on this and working on liquid biopsy. And clearly, another piece of work is to try and reduce entry into the neck by embolizing this prior to transoral robotic surgery for recurrent cancers. So clearly, it's not just one study that's going on. I have to acknowledge my colleagues, Zoltan Takas, who's the chair of chemistry at Imperial, my colleagues Jack Danda and Andrew Shackley, who are both maxillofacial surgeons, Lauren Ford, who is a physicist, and Burak, who's another physicist who helps out with this. Thank you for your time, and I hope that was of some use, but clearly it's early phase data, and I'm unable to share much more than what I have at this point in time. Over to you, Akshat and Alok. I'll stop sharing.
It was useful. I'm sure that people will be inspired by listening to you. Reason being, such things are definitely, they're a great motivator for people to come up with new ideas and to see how technology can be used to implement in clinical practice and move forward with that. Thanks a lot for that great presentation. Thank you. Smriti, can you switch on your video, please?
Well, one piece of recommendation I'd say is if you're planning to do some serious research, to certainly try and take time off. I know it's difficult in India, but if funding and other things allow, it'd be good to take time, because that dedicated time we take off during a post-graduation allows you to think like a researcher, think like a trialist, and it certainly helps lay the foundation for your future if you want to pursue a clinical academic career. If, however, you want to be a surgeon or an oncologist, that's fine. But if you want to go down the clinical academic route, if given a chance, I would certainly spend a significant amount of time trying to strengthen my research foundations.
Very right, sir. Very right. Towards the end, Smriti, are you there? Just to summarize, I will briefly tell, we had about 430 registrations for this workshop. And at its peak, we had about 150 plus people attending it, about 70, 80 through Zoom and similar numbers through YouTube. I would like to thank Smriti because she worked quite hard for this, and under the patronage of Dr. Alok Thakkar, of course. We would also like to thank Sarabjit as well as Amey, who helped with all the background work for this meet. So, thanks a lot. Thank you, Dr. Sharma, Dr. Gairola, Dr. Sharon, and of course, Dr. De Cruz. Dr. Alok, you would like to say something?
Just a thank you to everybody who contributed, including you. So it's been great. Thanks, Win.
Thank you. Good to see you. Thank you.
Yes.
Have a good evening. Stay safe.
Yes, thanks, Ben. Thank you. Bye for now. We'll call on you again one of these days. We'll
My pleasure.
So we should do this again, Akshat, one of these days. Bye, everybody.
Thank you. Thank you.